Welcome, everyone, to today's webinar, Optimize Your Revenue Cycle, 5 Steps to Boost Productivity. My name is Kelly Gooch, Senior Editor and Enterprise Lead with Becker's Healthcare, and on behalf of all of us, thank you for joining us today. Before I begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we are happy to help. With that, I'm now pleased to introduce today's speakers, Mike Morris, President and CEO of Extend Healthcare, and Billy Padilla, Chief Information Officer with Extend Healthcare. Mike joined Extend in 2016 and is responsible for the strategic direction, vision, growth, and performance of the company. With more than 30 years of RCM experience, Mike has earned an outstanding reputation for being a value-driven healthcare leader. He has led the transformation of Extend into an industry-leading technology-enabled services company that serves health systems across the country. Mike is an active member of the American College of Healthcare Executives, the Healthcare Financial Management Association, and the Healthcare Information and Management Systems Society, and a frequent speaker at industry conferences. He holds both bachelor's and master's degrees in accounting from the University of North Texas. Billy has over 20 years of experience in systems engineering, operations, and information management as a conceptual designer of Extend's proprietary inventory management system, PRISM, as well as the creator of the automated claim status module and early adopter of RPA technology. Billy has helped the company use these advanced systems to exceed best of practice parameters in managing operations. Billy manages Extend's application development and network operations teams that provide application delivery and technical support to more than 3,000 users at peak staffing across multiple locations, including users working from home. Additionally, Billy acts as the Extend HIPAA security officer, PCI compliance official, and principal HITrust contributor. Mike and Billy, thank you again for being here today, and I'll now turn the floor over to you to get us started.
Well, great. Yeah, thank you very much. Happy to be able to visit with everyone. I appreciate everyone that is joining today. The conversation we want to have is really a series of simple steps that are probably somewhat self-evident, but we find often that health systems will sometimes collapse some of these steps and makes it much more difficult to get to the outcome that you're trying to get through. So just real briefly on Extend Healthcare, we are a technology-enabled revenue cycle services company. And we've got kind of equal forces of both IT acumen and rev cycle expertise that are working together to try to help solve either an end-to-end problem for a health system or a subset of that revenue cycle end-to-end. And we're based here in Nashville, Tennessee, which is where we are located here today for this webinar. Quickly, before we start on kind of some background, you know, we are going to use an analogy throughout this hour about climbing a mountain, because the challenges that we face in revenue cycle are very much akin to trying to climb a steep mountain. It's not easy to get to the top. And just briefly, these are things I think that everybody knows, but we wanted to provide some 2023 data from a variety of sources around challenges. A recently published survey shows that the cost of hospital employment, so this is specific to hospitals, cost of labor across the enterprise is up 17% over the last 18 months. So that's a dramatic increase in cost structure, and labor is typically the most expensive component of hospital operations. At the same time, I think everybody's aware that reimbursements are shrinking. It's getting harder to get paid for the services that are being rendered from within a facility. And as your cash decreases and your net patient revenue it goes down at the same time your costs are going up, you get a net impact that you would expect. And in 2022, nearly half of U.S. hospitals were in the red, meaning they had a negative margin for that full year. Because of those cost and reimbursement pressures. So that's the mountain that we're talking about that we collectively have to get over. Now, if it was easy to get up the mountain, there'd probably be no reason to even have a webinar. But if you think about all the things that most health systems face, they may have a lot of different technologies that don't talk well together. They're underutilized. There's usually a lot of manual processes that have to happen in a certain order to get a claim properly adjudicated. There's limited account statusing, meaning that there's a lot of time invested in going out and trying to figure out the exact status of a claim that's with a payer. Root cause analysis sometimes can be inconsistent and incomplete, meaning when there is a problem, truly defining how to fix that problem once and for all is sometimes very difficult in revenue cycle. And then the reporting and analytics layer can oftentimes lead you to inaccurate conclusions because of an insufficiency of the data that goes into that reporting and analytics. And then layer on top of that the fact that in the revenue cycle, labor resources are highly coveted. So it's difficult to attract and retain talent within a health system. So when you've got fewer people, you got all those obstacles, and you got a great big mountain to climb, you got to do it a different way. And that's what we hope to be able to lay out, the path to get to that way going forward. So these are the 5 steps. And again, we're using mountain climbing as an example. Kind of give you the simple view of all this. You have to be able to baseline where you are today. You need to be able to audit all the underlying tools that you have to be able to perform rev cycle services. Then you want to benchmark, where do you want to be versus where you are today, and then set realistic goals to get there over time. You want to maximize automation as you go, because the more that you can do with a computer and the less you have to do manually, then clearly the more you'll be able to get done with a smaller team. And then what we call the summit is once you've got a redesigned technology and workflow methodology for your revenue cycle, you have to constantly measure and adjust, because it's a very dynamic process. It's not like you fix it once and you never have to think about it again. So getting to the summit is having that cycle where you continually improve over time. And Billy, I'll turn it to you. We got some terms on here that the team may not necessarily be aware of that are kind of fun to know.
Yeah, thanks, Mike. So first we'll start with anchor. So I think that's a pretty easy one to guess. Anchor is where we set our rope line at the bottom of the mountain, so that as we climb, we know how to come back down and we can use our cleats safely on the way down. Next up is the belay. So as we look at belay, this is your safety point. It's a place in which you can stop when you're in a free fall. And I think we really, when we audit our technology, it's a lot like trying to figure out where to stop. We're in a free fall. So, and then lastly, the word that most of us may not know is the dyno. So this is a dynamic movement typically formed in a jump from one side of a mountain to another, or from one place or foothold of a mountain to another. And so we'll talk more about the dynamics of that when we get to a little closer to the summit. So Mike, back to you.
Yeah, when you start looking at those technical terms, you realize that mountain climbing is pretty dangerous, and certainly trying to redesign a very complex process can be dangerous as well. We'd like to start with a question that will help us kind of determine who's on the phone today. That'll help us tailor some of the comments that we make. So we tried to boil it down to just a handful. We recognize we're probably talking to mostly leaders on the call. Some CEOs, some CFOs. Then we've got leaders within revenue cycle, as well as IT leaders that we suspect might be on. And then there may be some that fall into another category. So if you wouldn't mind, take a second to click on the one that most closely describes what you do for your organization. We would appreciate it. Computer is thinking. Here we go. Nice. So we got a good cross section, and including a lot of other, which is interesting. But we will. Sounds like we'll try to keep our conversation broad to address both operational and IT components of what we're talking about today. So we talked on that previous slide about the 5 steps. So let's dig in a little bit deeper on what we mean by each of these steps. So with respect to setting your data baseline, that's all about knowing exactly where you are today, regardless of whether or not you have efficient processes or inefficient processes. Very important to know what is your throughput and your QA measures in your current environment. And it's important to know that because that'll give you a sense for once you get to the benchmarking and goal setting stage, how much of an improvement you need to make. And the degree of improvement necessary oftentimes drives the timing associated with being able to get there on an incremental basis. The other thing we find really important during this phase is what we call a side-by-side observation. And Billy, if you'll share kind of how we do that in our environment on behalf of our customers, that might be a good example to share.
Yeah, happy to do so. So you might think of data side-by-sides not as data. But here we really feel that work effort that our agents and reps are doing in order to get these claims adjudicated is a very key data point. And so what we'll do is we'll come alongside our partners. We'll ask them to just work an account or several accounts very naturally, but while being observed. And we'll take good notes, try not to interfere in the process. It's important not to try to fix things during that process because it's easy to see something that may be easier that you know, but to really take that data back and then to do that same sampling across several team members so that then at the end of this we can kind of correlate that data and see where these elements of surprise are that we say, oh, this is something we can fix and help the process improve going forward. So, you know, that's where we base on kind of that users or that workers day-to-day work and create that into a data element. Get your mind.
Yeah. So the thing I might add to that is, you know, side-by-sides in the good old days pre-pandemic seemed easy enough, right? Because you had a team that was all co-located under one roof. But it's interesting that sometimes side-by-sides work even better in a work-from-home environment that many of us likely find ourselves in today with things like Microsoft Teams and other tools. It's easy for one or more people to be able to observe each and every keystroke that somebody is doing on behalf, you know, as they are working through either billing or following up on an account or even coding. And you can really get a lot of insight into the inefficiencies that may exist in the current environment that could be redesigned going forward. All of this, obviously, the purpose is to get an accurate baseline on the front end in terms of what it is that you need to improve from that baseline starting point. Next up is, this is an important step too, and where we see a lot of challenges across the healthcare systems that we interact with, and that is nobody's got the perfect set of tools and reports in place. You know, for those that have been in this business for a long time, electronic health records and patient accounting systems or practice management systems really weren't built originally to manage the workflow of revenue cycle. Over the last 20, 30 years, they've gotten dramatically better. So a lot of the things that you couldn't do with a patient accounting system, for instance, you can do much better today. But everybody likely uses a series of ancillary tools that wrap around that patient accounting platform that help people do their job better. So an ancillary tool, for example, would be a billing system. And Billy, why don't you share kind of the types of information that can be extracted from that variety of tools that could help accelerate that automation journey?
Yeah, so a good example of that is we take data from many of our clients' billing systems. There's a common report, a billing action completed report. And this report is very valuable to us where we're able to take that data and remove a work step from somebody where they may have to go back and follow up to see if that bill went out the door, right? So I think a lot of business offices are separated from their person who follows up on claims and the person who bills the claims. And so often we'll put in a request to have a claim rebuild, and there's a gap in knowledge there to know if that ever got done. And so we utilize heavily that report to see that process got completed from end to end. And then there's other, denials. Obviously, there's, ways to quickly ascertain, claims that didn't pass to, the cut. There's just a litany of different data elements that we pull from the billing system as we try to, again, move the ball down the field.
The other thing that I'd point out on this slide that's really important is that you can have the best technology, you can have the most insightful reports, but having a staff that's fully trained is becoming more complicated because there's a lot of opportunity for talented rev cycle professionals to go work at a variety of places. So you see a lot of staff turnover, and then the cost of labor is going up dramatically, which we covered on a prior slide. So oftentimes, if you're responsible for the revenue cycle for a health system, you're being asked to try to figure out how to do all this with a smaller footprint of people, some of which don't have the same number of years of experience because of that inherent attrition in our industry, that you've got to be able to get that team up to speed so that they can use all the tools and reports that you have in place. Lastly, I'd say from a reporting perspective, we see a lot of reports out there that are just kind of a static view at a point in time, but they really don't give you a full view of the appropriate actions or timeliness with respect to those actions need to take place in order to keep all of your KPIs green. So that's a challenge that is pretty basic across the health systems that we interact with. And the good news here is nobody's got it 100% figured out. And there's always opportunities to improve that technology and reporting environment to be able to make better decisions going forward. Okay, we're now at step 3. And so earlier we figured out where we are today. The next step would be to set a realistic benchmark of where you want to get KPI to. And I did see, I think we're going to have some Q&A over time. And I saw, I think in the inbox over here, what are some of the most insightful KPIs? And there are a lot of them out there to be able to measure, but those that I tend to put the most focus on are those that accurately help you measure net patient revenue, which is what your cash yield ought to be, and then what percentage of that are you achieving, and in what time frame are you achieving it. So there's a variety of KPIs that will measure all those things, but at the end of the day, that's going to tell you, are you getting paid everything you should? And is your net patient revenue correct? Meaning, are you getting everything onto that claim that you are entitled to reimburse for? And then how quickly do you get it? So if you got those 3 things correct and clean within your rev cycle environment, then you're doing very well. It's harder to do than it seems, but from a benchmark perspective, knowing where you are today and then trying to get there in a reasonable amount of time. I see frequently somebody's KPI will be in the red. We'll use AR over 90 since that's when you see a lot out there. You may or may not be able to get to a best-in-class benchmark depending on what your payer mix looks like. So as part of that benchmarking exercise, I think it's important to be able to get a little insight from your peers as to where they are based on their mix of inventory so that you can set a realistic goal for your facility. And then once you do that, then you also have to recognize you're probably not going to get there immediately. There's a march to get there that's part of the climb, and being able to set those goals over time, I think is one of the challenges that we have. Sometimes you'll set a goal and/or a path to get to that goal that just can't be done in the time frame, which ends up demoralizing the team that is on the climb with you. But you also don't want to wait too long. You can't say, here's where we want to get to, but we'll allow a year and a half to get there, because with the negative operating margins that many of us have, we don't have the time or the luxury to be able to wait too long to be able to clean something up that could be done better. That last sentence on the page, I think, is of interest, and I know, Billy, you want to jump in on this, but there are ways to get up the mountain faster, and it's by prioritizing the issues that are a drag currently on your ability to get to benchmark and goals. So, Billy, you want to weigh in on that?
Yeah, I can share a couple ways how we have addressed this here. So in our inventory management system, we are able to set up prioritization queues. So we have several queue types, from a locked queue, meaning this account has effectively a 0 priority. Nobody should be working these accounts because we either have, evidence that it's going to pay, in near term, just a lot of reasons why these accounts shouldn't be touched just yet. Then we have our shared queues where we can give people access to prioritized work lists. And these are generally our more seasoned reps that we can allow a little bit more direction, self-direction, if you will. And then lastly, we have our Get Next queue. And this is a prioritized queue that allows us to feed in a heavily prioritized list of data elements where we take, several elements across these KPIs that you mentioned, Mike, and then we can put those into a prioritization score and get these accounts worked in a way, one after another, so that we can ensure that, things like timely filing are contemplated in the working of accounts. So, we look at all these different large impact items, try to boil them down so that we don't leave anything left behind, and work them in an efficient and timely manner.
Great. So next, once you've gone through the first 3 steps, step 4, you're getting to the dyno stage, and that is identifying opportunities to automate things that are currently being done today. And one of the things that we do that we have found that is highly successful and seems to build a lot of employee morale is we actually have on our intranet site the opportunity to input ideas into what we call the idea exchange. So essentially, we are crowdsourcing opportunities to automate things that are currently being done manually. And at first we thought, well, we may have an issue because someone that is a patient account rep may not necessarily want to disclose what could be automated because they might be automating themselves out of a job. So that was a fear that we had, and a common comment that you hear in the industry. The reality is we saw just the opposite. I think that most of our team, as well as your team, wants to work on more meaty things and doesn't want to do mundane, redundant things. So this intranet capture of ideas around how to automate has really worked well for us. We typically get 5 to 10 suggestions spread out over our customers on a weekly basis. And then that feeds a process by which we can go in and analyze whether or not it's something that makes sense to do and how we prioritize that. And then we feed that to our application developers in a prioritized order so that we're able to enhance and update our system over time. So hopefully many of you do something similar to that, but formalizing that process has worked well for us. And then we've even attached some financial rewards associated with the best ideas that come up. So on a monthly basis, we evaluate them and we try to provide a token financial compensation to those individuals that had the best ideas, that had the largest impact on our business. The other thing that is very important is as you start to find things that can be automated or more efficiently done, document very carefully those things that are still done on a manual basis, and then share that information with process engineers and leaders as well as PARs so that they can understand where there may be an opportunity to automate further. And oftentimes when you say a process has to be manual because it's just no way to automate it, it's because you need to break that process down into a handful of discrete steps. And then sometimes some of those steps can be automated, even though the full end-to-end process continues to have manual components associated with it. And so we're going to show you an example here in a few minutes of how we do that in our environment to make sure that we can continually reduce the amount of manual intervention when automation and workflow enhancements would be a more effective and faster way to achieve what has historically been done manually. Billy, any thoughts to add on the automation front?
Yeah, I think this last bullet kind of ties back to that previous side-by-side that we talked about. So as we take these documents, and while we're in that side-by-side, we can compare the process that a person's actually doing to the documentation to make sure there's no gaps to that, and then to also ensure that we're fully training the staff, right, and making sure they're doing it in that most efficient manner, because it's easy to fall back into bad practices. So we may determine, hey, if you go to this window and search, it's much faster than going through these 4 different windows to get to the same result. So, I think these things dovetail tightly together, the constant evaluation of the staff and the clear documentation of the processes. And this, again, lets us boil down those repeatable steps that we can pass over to RPA or some other robotic technology to enhance that ability.
Great. So this is the what we call the summit, and that is once you've gone through the redesign effort and you feel like you are where you need to be and as far along as you can be in terms of optimized revenue cycle and automated functions, that's when you have to constantly go back and look and evolve your goals over time and make sure that you recognize that even when you're at a summit, chances are you're really not at a summit, you're just at a plateau with another opportunity to climb higher. So the thing that I think is super important is to recognize that this whole process never really ends, and being able to focus over time as tools improve, as reporting improves, you may be able to find additional ways that you can get just a slight increase in productivity or QA associated with the work function. And you should always seize the opportunity to do that, because our sense is that it's not going to get any easier to run a health system in the future than it is today when it comes to the financial metrics and the cash flow needed to be able to keep the doors open at a facility. So I think that we'll constantly be called upon in the rev cycle business to make sure that it's being done as efficiently as it can be. And as new opportunities arise, that we jump on them quickly to be able to take advantage of them. So that measure and adjust, although we call it the summit, it's probably an iterative summit, and the summit grows over time in terms of what more can be accomplished. All right, let's jump to the next slide. Great. Okay. Here's as we go through those steps, we recognize that probably there's no health system that's still wholly on step 1, and there's probably not a lot of health systems that are all the way at step 5. So we kind of wanted to get a sense on where the audience is today in terms of either getting started, making progress, or leading the pack. So if you don't mind, just taking a minute to pick one of those 3, and that'll kind of help us guide our discussion going forward. All right, I see responses coming in. I appreciate that. This really cool website should convert it into results that we can all see in just a second. All right. Yeah, as we do this presentation, it's interesting. Most people fall into that making progress or getting started somewhere between those two. Very few facilities declare that they're leading the pack. And that's frankly because there's so much still to be done that I think it's, I don't know that there is a leader of the pack yet when it comes to getting a fully redesigned and optimized revenue cycle. So these are consistent results with what we typically see. All right, we have one other thing that we want to kind of a practical application of everything that we've talked about. And the good news is we're not going to walk you through all of this, but this was an exercise that we took several of our clients through to completely redesign how they did follow-up. So this is post-bill drop. What's the most efficient way and most cost-effective way to stay on top of that inventory that is open debit balances at the time. So you'll see on the left-hand side, there's these 4 swim lanes. And what we found is when we got a team of people and a whiteboard together, we were splashing into other swim lanes. So let's kind of walk you through it real quick, show you each swim lane, and then gray out the things that are not relevant to the slide or to the discussion. So if we go one more slide forward. All right, whoops, we went one too far. Okay, the first swim lane is very technology focused, light labor footprint associated with it. So Billy, if you'll kind of share what we do when we've got a claim and we're trying to learn everything we can from the data that's available about that claim before we have any manual intervention.
Yeah, so this is where we're doing our baseline step, right? So this is where we baseline the data. We look at all the data available. Do we get X12 data, 837s, 835s, the billing system data that we talked about. Just, we kind of really boil down all the data elements that we can use to do that prioritization that we talked about later on in the steps, where we can now, know what accounts not to work, what accounts should be worked next, things of that nature. So we're going to look at, all these disparate systems, try to tie that account together to give a holistic view of that account, not just what's in an EHR, not just what's in the billing system, but this holistic view so that we can know the next best action as we move it down this continuum of effort. Then we're going to make a lot of decisions. Does this need to be worked manually, or can we move this into a path of automation? There's just a lot of decisioning processes that take place here. And again, these are decisioning processes that are not labor intensive. They're computer, processing intensive as it's making these determinations on our behalf.
Yeah, and we talked earlier about that side-by-side viewing of what is being done by teams within business offices. And it's interesting that data gathering is something that takes up a lot of time. And we see for a lot of payers that there's an inordinate amount of time just going and trying to track down what a status might be on a claim. All of that can and should be able to be done through intelligent automation if you've got the right data. So back to step 2 of the process, it's analyzing the data you have, making sure you're using it all to the fullest extent that you can. So once you've gotten through that step, you may find that step 2 is unnecessary for the vast majority of the claims you're looking at. But if you go to our pre-status process, Here you go. So this is these areas here in pre-status. This is only when you can't get the info you need. So you end up on information not found at the end of that step 1 automation. Then what we do, or we find for some facilities, it makes sense to be able to then go in and take that smaller subset of inventory and assign a team to it. Some of you may use offshore today. Some may do all work events onshore, but this pre-statusing is something we found that if you do use offshore, is something that you can get done at a much lower price point very efficiently, because essentially what you're doing is you're going and gathering data that you couldn't get through an automated process, and then you're trying to triage and identify that current status of the account so that you can queue it up for an upcoming work event or a prioritization effort based on the information that you're able to find manually. So we find that if the best way in our mind to do that is by allowing people to practice at the top of their license. So if somebody is relatively new and has a year or so of experience, they may be great candidates for that pre-statusing team because they know enough to be able to do that triage, but they may not necessarily be the right resource to handle a complicated denial on an inpatient claim or something where you'd want a more experienced person. So we broke it down into this kind of pre-status process for our customers in order to be able to quickly get to a point where we could then enter an automation phase with this workflow automation. So I'll let Billy walk you through workflow automation.
All right, so this is where we talked about some of the queue processing. We take that data, we boil it down, and then and sorry to keep referring to how we do things. That's just my area of focus, but I do believe this is relevant across the continuum of healthcare. But we take these accounts, we boil them down, we look at things like balance. I don't want to read them all to you, but all of these are very important. Discharge date, timely filing. We have a national payer list that we've built internally, and we have their timely filing guidelines for every one of those so that we can easily have the system tell us when that account needs to be worked. We're adding features to this all the time. Like some payers, their timely filings from discharge date, where others are bill date. So we have to accommodate for those nuances in that payer's requirements. So we take all that, we boil it down into a prioritized step of work so that we can feed those accounts either into one of those queues that I mentioned earlier. Either we feed it into a locked queue that says, this isn't ready to be touched. Somebody worked it yesterday, or we have, a remit that says it's going to be paid tomorrow. We have, specialized queue, and we push that, account, high dollar Medicare account to a specialized Medicare worker. And then we have the other, highly prioritized accounts that we push into a group of trained PARs that can just take, the next best account to be worked. We do break that out by payer so that they're not context shifting all the time, but we're able to really feed and optimize their work effort against this list of steps that we've prioritized.
And a couple of thoughts. Go ahead, Billy. I'm sorry.
No, I was just making sure I covered all your points you wanted, Mike.
Yeah. One or two things I was going to add is mentioned earlier that many patient accounting platforms have made significant strides in being able to do some of this. And we also talked earlier about redundancy. You don't want to have tools that have redundant capabilities. So you may find, depending on the platform you're working in, that this automation and prioritization and scoring can be done within your native system. But when it's not, that's where an ancillary tool could come in and be highly effective at being able to identify the next best account for somebody to work. So that takes us to this fourth swim lane, which means that we're back into the realm of people doing manual processes. but that get next function we think is really important. In fact, a lot of the times that we do our analysis, we'll find that people doing follow-up have a pool of accounts that they can go to perform work on. And oftentimes you'll find that when you're pulling an account out of a pool of accounts to work, you may not necessarily be doing it in the optimal order. So this concept of get next is designed to isolate, make sure that next most important account is the one that's worked. It also has an aggregation feature because let's say you've got a follow-up that's unfortunately going to require a call to a payer. You want to make sure that you've got multiple accounts queued up so that when you do get somebody on the phone, you're resolving more than just that one account that get next popped up. So having all of that logic and business rules built in has really helped us get through inventory much more quickly and has allowed us to kind of help our customers keep green KPIs because they're working the inventory consistent with the KPIs that are important to them. That helps keep all of those green. So we've got the, we call them the PAR team or patient account representative team that is going through using Get Next to be able to get to the inventory that they should get to. With a goal, obviously, of one-touch resolution. To the extent that we don't have to go back and revisit a claim, then we're obviously better off. And obviously, you would prefer not to have any follow-up necessary. If the bill goes out the door cleanly and you capture everything from a data perspective, you might be able to get everything auto-posted and get that claim fully adjudicated without anybody following up. Unfortunately, that doesn't happen 100% of the time. That's where you need a PAR team to go in and fix issues to make sure that that AR is getting paid. Last thing I'd mention here is that, over all of these processes, you need a robust QA process in place to make sure that the work events that are being done are done in a quality manner. We spent a lot of time in this particular presentation talking about productivity and how do you get through more inventory. But you never want to trade more productivity for less quality. So we do infuse QA for all of our customers to make sure that that AR is being handled appropriately, whether or not it's handled by an individual or by an automated process. You need to audit it all. And then when you do that, I think you get good results. And this is just one example of what a redesigned workflow could look like once you've gone through those 5 steps of climbing the mountain that we described. So with all that being said, last thing that we'd be curious about is we're all on a climb to the top of a mountain. We don't know how tall that mountain is. A lot of facilities are going it alone with internal teams, and some use a mixture of internal and external resources. So just curious, either one or two, is it an internal only climb, or do you use partners to help get to the top? The calculations are happening now. Well, interesting. We got 100% on a mixture of resources, which does make some sense, right? I mean, there's either a technology vendor or services vendors typically are side by side with our customers to try to get things done in the most efficient manner possible. So appreciate that feedback. And with that being said, I think we do have a couple minutes left. We want to make sure we get done prior to the top of the hour. But if there's a question or two that we can tackle, and then anything we don't get to, it looks like there was a lot of questions came into the inbox. We will follow up on 100% of them, but hopefully we can cover one or two during the session.
Yeah, thank you so much, Mike and Billy, for that presentation. As you said, we'll now begin today's question and answer session, and a reminder that you can submit any questions you have by typing them into the Q&A chat box on your webinar console. And if we don't have a chance to answer all the questions, we, of course, Expense team will be following up to respond to your questions. So we can go ahead and get started here. Mike and Billy, one audience member wants is wondering about your thoughts of automating and digitizing the mailroom process within a health system.
I'm sorry, was that the mailing process? Did I hear you correctly?
The mailroom process, yes.
Mailroom, okay, yeah.
Yeah,
So,
correct.
yeah.
Yeah.
Yeah, so I'll offer a couple thoughts, and then Billy, feel free to jump in as well. Yeah, the mailroom is something that used to be very, very manual, and now is highly automated. In fact, a lot of things that used to be done through the mail are done through automated processes to cut down on the amount of paper associated with it. But we do have, a good example of where we have automated is when a payer wants to have a claim appended with a medical record and wants a physical copy of it. Although we call it the mailroom, it may not go through the U.S. mail, but we do have processes in place that allow for the proper identification of the right record and the appending of that record so that it can be transmitted electronically to a payer. And managing all that process so somebody's not standing in front of a photocopy machine like we used to do in the past is a good example of where we use automation to do what we used to do in a highly manual fashion. Billy, any other?
Yeah. Sorry.
Yeah, go ahead, Billy.
I was going to add quickly. The mailroom, I think, is a good, kind of a ripe area for automation, as Mike mentioned. It's not without its complexities. I do think it typically, to automate it well, you're going to have to find the right partners, to handle that, the stuffing of the envelopes, the sending of the mail, the things that are so complex and time consuming there. But I do feel that the mailroom is while it may not be the best value, because typically the expense of the mailroom, depending upon where it's at, may not yield the same level of automation elsewhere. But I think for consistency's sake, automating in the mailroom is very valuable. So hopefully that helps.
Yeah, also very compliance officer friendly. Mailrooms typically scare compliance officers because it's PHI that's hard to track.
Thank you. We have another question here as well, and the question being, what will be the first area to start automation?
Yeah, Billy, you want to start with a good place to start?
Yeah, there's so many good places to start. But one place that we started was just, kind of this whole thing. You have to start somewhere. So start with a simple, repeatable process. Most systems have an ability to tag or flag or whatever the vernacular is in that system an account so that it doesn't fall into the work queue, at least for a period of time. And so, I think claim status data is very valuable, where you can take just take the known universe of claims that are set to pay by your payer, and where you can't already do so automatively in your health system, automate that task. So go in and flag that account so that you don't have that account be pulled into somebody's work list when you already have data that tells you that account's set to pay. And then quickly thereafter, take that same set of data and those accounts that have denials on them, increase the priority on those. So there's a lot of rich data around that claim status, and it's a good place to start.
Yeah, and the only thing I would add to that, I think, Billy, you're spot on, but one thing I like to do is go look and do that visual observation and side by side to see what the teams are doing now. You'll probably be surprised by what percentage of someone's day gets consumed doing something that doesn't appear to be done or needed to be done on a manual basis. So that's oftentimes where I think the best place to start is where's your highest spend with the lowest yield associated with it.
Great. Well, we have just a couple minutes here and left, and so we'll end with this question here. What are the most insightful KPIs for monitoring RCM success?
Yeah, so I mentioned a couple of them earlier. I think the ones that mean the most to me are the ones that indicate that, or help measure how quickly a claim is coded with all the appropriate information. So that's a mixture of speed as well as QA, as well as a precise calculation of net patient revenue, which is your expected yield, and then how quickly you're able to get to 100% realization on every dollar that you should have gotten. So those are the ones that I tend to focus on because those are the ones that tend to drive more positive cash flow more quickly for an organization. I know that there are professional organizations that publish, I think there's one that's got like 25 different KPIs, and they're all good. And they all tell you something insightful, but those that are the ones that tell you, are you getting all the cash you should get, and are you getting it quick, are the ones that I think are the most meaningful to me. Billy, do you got others you want to throw out there?
I think you covered the highlights, Mike. There's a lot of things that are very particular to a health system that we may not see from a revenue cycle side. So I think as you look at your KPIs, you really need to kind of that self-assessment. What are those internal factors that help you see success as you move forward?
Yeah. The last thing I'll close with is that although the organization I mentioned has 25 different KPIs, I think that's too many. I really think that 5 or 6 KPIs that matter to your leadership team are the ones to focus on, because if you're measuring too many things, sometimes that's over-analysis paralysis that you want to try to avoid.
Well, thank you so much, Mike and Billy. It looks like that is about all the time we have for today, and I want to thank you both again for an excellent presentation, and also Extend Healthcare for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you to everyone for joining us today, and we hope you have a wonderful afternoon.
Thanks, everybody.
Thank you all.